This podcast is sponsored by PAX. Whether on water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Renowned for their durability, they endure harsh conditions while providing rapid and reliable access to essential kit. So their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. PAX bags are designed with infection control in mind and are easy to clean and disinfect. Their highly visible colours and reflective strips add quick identification and adherence to quality standards, assuring reliability. The versatility of PAX bags caters to a diverse EMS providers, but also delivers vital equipment and durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations and they're absolutely excellent. Please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, we're going to be speaking about tactical medicine and really dig into the high threat care with our guest, Stephen Wood. What we're to do in the episode really is talk to Stephen and really unpack his background and indeed the podcast he runs, Tac Medic Whiskey podcast, but also just dig into his background as a nurse practitioner and educator, and indeed his work with tactical teams and some of the experience he pulls through into practice, and really draw that out in the episode. So he has become a prominent voice in the evolving landscape of high-threat medicine, and his podcast really digs deep into the challenges and indeed innovations of tactical pre-hospital care, blending his insight with real-world experience. And in the conversation, what we do is really look at everything from the use of TXA and calcium, chloride and trauma, to also the nuanced decisions between the decision to needle decompress someone versus finger thoracostomy. But we're also going to talk about the importance of team cohesion and some of the larger soft skills around the mental models and toll of working in this kind of environment. We're also going to look at building resilience in the field and also the role of emerging technologies, but also what the future might look like in tactical medicine. Steve, welcome to the podcast.
Thanks, Owen. It's a pleasure to be here and to chat with you, as always.
Yeah, it's great to have you on. Actually, I guess it'd be nice just to start really, Steve, and really get your journey, your organic journey, as to what inspired you to specialize in tactical medicine.
Yeah, I mean, honestly, I've been pondering that question myself. I started out. I already knew in high school that I wanted to be in some field of medicine. The high school that I went to, you had an option to actually take some courses that would give you in classroom, but also experiential learning. So I went to the ER, I went to like radiology, and then I rode on the ambulance, and I realized that was what I wanted to do. I wanted to become a paramedic. So I got my EMT. I then moved on, got my paramedic, worked in the street for a number of years. And, I always, the area that I worked in is, Metro Boston, and just really, loved the chaos of that city. It's one of the poorest cities in Massachusetts. It was at one time taken over by the state. And it was a little bit chaotic, and I always enjoyed that piece. I then left the street and went to do 10 years in helicopter EMS, during which time I actually thought I would get out of EMS altogether. I got a bachelor's in biology with a plan to maybe apply to medical school or PA or NP. Got a master's in toxicology, thinking I'd want to go work in a lab. And did that actually for a little while for the New Hampshire State Police. And so I think that was kind of my first foray into hearing about, kind of specialized tactical medicine, austere medicine, because they had a team there that, would go into the drug labs. That was not my role. I was in a lab, just testing blood for drugs and alcohol, but I got to see that team and got to see what they were like, and also was under the umbrella of the New Hampshire State Police, so got to get a little bit of kind of a taste for what law enforcement is and what they're doing. I however left that lab because I did really miss clinical medicine. Went on and got my nurse practitioner, and was just working in an ER and really not too heavily involved with the EMS until the opioid epidemic struck. And because of my background in emergency medicine and in toxicology, I started working with some local law enforcement agencies and EMS agencies to kind of, get a handle on the opioid epidemic and got to ride along with a regional drug unit. I went out actually once a week, almost for about 5 years, with the drug unit and their detectives. And that's where the bug bit me is like, I loved that experience. I wasn't there as a medic. I was there in a different role. But I knew that this kind of work was something I was interested in. And so did get hired into an agency that staffed medics for a regional tactical team. It is a tactical team that consists of 64 different communities. So they send their SWAT officers, and then we were their medic support. I was with them for about 3 years. It's a busy unit. There were a lot of high risk warrants, a lot of barricaded subjects. We did have, the protests during George Floyd. We were involved in that. Um, there were some incidents that I wasn't involved in, but, got to at least learn from. So I really, realized, hey, I really enjoy doing the tactical medicine piece. But, one of the issues with that unit was that, we were kind of seen as we were there as medics, but we weren't really necessarily part of the team. We had the same uniforms, but we didn't train together. We, didn't really engage that much with the team, except, we're sitting there and we're with that unit in case they need any medical care. But after, leaving that unit, I was able to get on with another unit here in Massachusetts that is really an incredibly good organization that has fantastic leadership. And because of that, I'm heavily integrated into their team. I mean, yesterday we had training. We took our Bearcat out. We were doing breaching, we were doing flashbangs, we were doing entries, but we were also doing officer down drills. And, my role there was to, run those officer down drills, from the medic standpoint. And I'm always asked by the leadership, any other medical tactics we should be thinking about, any other kind of medical, considerations. During briefings, there's always a medical, brief. And so I'm thankful that now I'm with a really good team with an amazing leader, and well integrated into that team. And so, now it's really, okay, how can we grow this? And I'm learning a lot of things that like I hadn't thought about, that is really different from what might do in the, standard pre-hospital setting. And it's been a great experience. And so it's something I really enjoy doing. And, I teach full time, which I love doing. I work in an ER, work in the ICU, but like my days with SWAT are my fun days. That's where I, have the most fun and just enjoy doing it.
Yeah, indeed, indeed. And I guess in a way, my question on the back of that would be around how you balance the duality of roles, like you said, as an educator and as a clinician, because I think, like you said, there's the push-pull of a busy ED or indeed a busy a busy primary care unit, but also then like you said, stepping into a tactical role where there's different, I guess, in a way, as an educator, but also as a clinician as well, there's different drivers, and it's a
Yeah.
mindset shift in a lot of ways. Could I get you to speak to sort of that push pull of, I guess, in a way, being across multiple teams?
Yeah, I mean it is interesting because I work in the emergency department, and it's a busy ER. It's not as busy as some of the hospitals here in Boston, but it's busy. And in the ER we complain about EMS and police bringing us patients that we don't want. You know, police, those blank cops bringing in this drunk again, um, or someone who was engaged in an assault coming in handcuffs. I see both sides of that. So I do hear that. I hear that, but I also understand now the law enforcement piece because I've been with these teams and I get to see that piece and their responsibility is to make sure, yeah, is to enforce the law, but also for the safety of people in the community. And so it's a tough job for them to do. And then in the ICU, we complain about the emergency department because we're like, well, why are they admitting this CUPD on BiPAP? I could have treated him in the ER with BiPAP, some nebs and steroids, and like admitted him to the floor. So you do see, I get to see it all. I mean, I get from the law enforcement, EMS, into the ER, into the ICU. So it's really just, the way I approach it is I keep to myself a lot about, complaints, and just do my role because I've been in that duality for so long. I'm just going to do my role. I do complain about the ER when I'm in the ICU quite a bit. I'll take that back. But, um, in the other settings, yeah, I mean, when the cops bring someone in drunk, I feel for them. It's what they have to do. So, that's how I kind of balance it. I'm a paper calendar guy, and a daily list of things I need to do, and that's how I manage my time. Is just making sure I can fit in all these different roles, fit in the education that I need to maintain, currency. But mainly it's also, you know, I feel actually pretty, lucky that I get to see all aspects, and that gives me a much greater respect for everyone and everyone's role in this whole medical system.
No, absolutely. That does answer that. And actually, Steve, like you said, having granularity, that perspective actually in different people's shoes. And we've spoken about this before, about you get the people that have done pre-hospital care because when you're on the inside, maybe receiving those patients, you can just see the face of the pre-hospital practitioner and you can just understand maybe some of the hell they've been through. And there's just
Yeah.
that general extension of empathy there. But let's pivot slightly and really shift it around to something you cover a lot on your podcast. And I just really like to drill into this because we're starting to see the evolution of blood products within pre-hospital care, certainly in the US and
Yeah.
within HEMS teams and tactical teams, being a real driver for offsetting mortality and indeed morbidity. But as an adjunct and maybe a package of care, Steve, looking at the adage of tactical teams carrying TXA, carrying calcium chloride if they do give blood. Could I get you to speak to sort of this package of care in hemorrhagic shock? Have how these treatments have evolved in tactical medicine.
Yeah, so I'm a huge proponent of pre-hospital whole blood. Anyone who listens to my podcast or has read my pieces on this, I talk not only about the clinical issues but also the ethics and equity issues around pre-hospital whole blood. I mean, I've been in EMS now for 30 plus years. To me, it's the most important intervention that has ever come into EMS, 100%, without a doubt. So I think that we have a special project here in Massachusetts for two agencies that are carrying blood. They're carrying, low titer O positive whole blood. They've had incredible success. I'm not currently carrying blood. It's something that we're looking into because I want to have it available. I do carry, so my trauma package consists of I carry TXA, and we need to know that TXA is a great drug, but the change in mortality is around 1 to 2%. So it's great, but it needs to be as part of a package. So I do carry TXA. I do carry calcium chloride. And I carry calcium chloride not just because of if you're going to be giving citrated blood products, but there's some good data that in that diamond of death, we've got coagulopathy, hypothermia, acidosis, and hypocalcemia, and that calcium can be important to restore the ability to, vasoconstrict, to clot. So I carry calcium chloride also, and I'm not paid by any of these companies. I'm not endorsing any product, but there's a product called Trauma Gel. It's comes in a syringe. It looks like miso soup. Um, and it comes in a syringe, and you can inject it into the wound, and it basically creates this matrix that blood can adhere to and creates a clot. And it can stay there for a while. It's easy to remove. You don't have to apply as much pressure. It's great for junctional trauma. So I carry those, and I carry antibiotics. So I have both ceftriaxone and cefazolin. So in my bag, I've got TXA, I have calcium chloride, I have trauma gel, and I have ceftriaxone and cefazolin because I happen to just accumulate that at one point. But that's what I have. But I do think that next step is to get whole blood so that if we're going on a high risk warrant, we know that it's a situation where there could be risk to, high risk of injury. I want to have that blood with me. And, one of the really cool things, well, we've both been able to teach down at the FDNY, MSOC conference. And, from that spinoff was we also now are teaching some classes to the Navy SEALs. And so we go down there. I've been down once. We're going back again in June to do another class for them. But they carry whole blood in a backpack. And there are items out there, whoever you want to use, but Pelican, what have you, that can store blood at the right temperatures, monitor it, for up to 72 hours. Hopefully, I'm not going on a call that's 72 hours long, but I think that's going to be my next step is really looking into how can we actualize this for my team and for the other teams. We have, I think, 3 or 4 regional teams here in Massachusetts, so I think that we could do a special project waiver with the tactical medics carrying whole blood. There are logistics to that, of course, which are going to involve, coordinating with a blood bank and, rotating that blood. But those are not hurdles that you can't overcome. And that's been one of my biggest issues has been for those people out there trying to blockade this, despite the growing data, is that they're saying, well, we have so first it was, oh well, allo immunization, and in women of childbearing age, that could downstream affect their neonate, and we know that's just absolute garbage. And then all the other risks of blood transfusion reactions, we know they're less than 0.1%. Whereas the mortality difference is like 40%. So to me, it's a no-brainer. It's very safe. It's easy to do. I mean, I've simplified it even down to saying, well, you can either hang clear fluid or red fluid, and you just use different tubing. And here's the things to look for. It's really much simpler than we're making it out to be. But the second blockade is, well, rotating blood and waste and all of these issues. And certainly there's going to be some waste. But where I see the most waste is when I'm working in the ED or in the ICU and their hemoglobin's less than 7. They're admitted here for pneumonia. They have end-stage renal disease, but, and they have, they had an NSTEMI. And so let's give them, 2 units of packed red blood cells. The mortality difference for that is 0. Whereas with pre-hospital whole blood, it's proven to save lives. And there are many, many examples of this. And some great, people speaking about this, Peter Antevi, Mark Peel, those guys who are just, really the drivers, of this. Here we have Dr. Mike Valkanis, who's, along with Ben Pizzadlo, who is a long-term paramedic, put that system together, or were the drivers behind that. So, and they did it. They were able to figure out these pieces and engage those obstacles and overcome them. So I think, yeah, that's where I'm sitting here, sitting with with regard to blood, and I can't understand why we can get paramedics Zofran and Toradol and, all these other things that honestly make really no difference in outcomes. But we now have a proven intervention and, it stalled in many locations.
Yeah, indeed. Well,
Here in Massachusetts included. Yeah.
yeah, I mean, there's an interesting intervention which we're going to do a podcast on with a few personnel from NATO in a couple of weeks' time around spray dry blood. And on the concept here is there was a conference last week in the UK around essentially around withdrawing blood from a soldier, spray drying it through a certain robust process, and then reconstituting it with saline and giving it back to the soldier. So essentially what doing is carrying it in the backpack in a almost like a freeze dried quality, but
Yeah.
it's the soldier's own blood, so there's going to be no reaction to it, and you can reconstitute it with saline. But essentially, what that does is gives you whole blood back to you if there has been a significant at point of wounding, a significant injury and or penetrating disease. But this concept is to your point around facilitating blood banks and circulation and storage times and cooling times, but actually getting a personnel's own blood, freezing it, constituting it, reconstituting it in quick time is an absolute game changer. So we're gonna get a couple of those guests on the podcast just to really dig into that.
Yeah, no, that'd be fantastic. And I think there's a real need here for, yeah, we need to figure out how to actualize this, sustainably. And so I think that's a great idea. One idea I've seen is there are departments that give whole blood, they do a blood drive. And so that's one way to contribute, but advancing technologies is going to be key as well. I have to laugh because when I was doing my degree in toxicology, there was a lab next to us that was also trying to do synthetic blood. And we were doing what was called a live heart model. So we had rat hearts that were hooked up on like a little mini bypass that a glass blower actually made, which was very cool. But we were just looking to see, what certain drugs may affect ischemia. We were looking at different Chinese herbals. I know this is going way off topic, but Chinese herbals and in myocardial ischemia in a rat heart model. But if we wanted to end the experiment, we gave it that blood because it stopped the heart immediately. Yeah, it's terrible, but we do need to, this was 20 years ago. So there were labs looking at, can we make synthetic blood products 20 years ago? We need to really start to advance either synthetic blood or can we do other ways to like reconstitute this, right? This, like Mountain House, lasagna that you take on your camping trip, right? Add some water, you got your lasagna. We need to do that with blood. Um,
Yeah.
but yeah, no, I mean, I hadn't heard of that, so that's fantastic. I know, people are looking at freeze-dried plasma
Yeah, indeed.
as a
Yeah, lab-based.
potential agent, so that's coming downstream. I think, this is going to be an important time in our careers to see what's going to come down the pike.
Yeah.
There really needs to be a strong effort to better actualize this and make sure that people have access.
Yeah, indeed. Steve, let's pivot slightly and look at pleural drainage and just your approach as an educator and clinician to pleural drainage.
Yeah.
We do know the adage of needle chest decompression is sometimes limited by the chest wall and just the appearance that pleural drainage is taken care of when actually there is no breach of the parietal pleura and visceral pleura to actually get to that potential space through a cannula. But true to say, finger thoracostomy has got its own issues where if it's not a ventilated patient, that you're starting to introduce significant sized holes into chests and actually can create issues in any kind of self-ventilating patient itself. Could I get just you to speak to and maybe indeed run us through your approach to pleural drainage?
Yeah, so my approach is finger thoracostomy. So I've done at least hundreds, if not maybe 1,000, needle chest decompressions in my career. And my experience with them has been if you can actually get into that space, good. But it's unlike, as you mentioned, especially here in America, where we have, a problem with obesity, that becomes more and more difficult to do, even with the needles specifically designed for that purpose. And I do carry them. I carry them on my bag. They're on the outside of my bag, for quick access. But right behind that is my scalpel, so that I can, do a finger thoracostomy. So, I think that one of the things that, with needle decompression, it is a blind procedure. So you are, going in fairly blind with that. And, despite, knowing your landmarks, anyone who's done enough of these has put one in someone's, myocardium. And I know I have. And so, or the needle just is misplaced and you're not in the right spot. And all of the little tricks and trade that we do, a syringe with some saline to see bubbles, or the little glove valve, those things are fallible. So, I think at least with the finger thoracostomy, I have full control over the anatomy. I'm going in, I can feel the ribs, I can then, excise through that, and I can feel the pleura. And then, we make our entry that way. I feel like it's actually a safer procedure, from that standpoint, because I'm directing, all aspects of that. I know where where I'm making the hole. Identifying the intercostal space, and then I'm identifying the pleura, and penetrating that to relieve the tension pneumothorax or to relieve the hemothorax. And so I personally, it's my go-to, and that's what I'm going to do. I've done them in the ED. Both of them I've only done it, twice. Both of them actually were for massive hemothorax. And it was a little surprising actually when the blood started pouring out. I probably should have been a foot or two further back. But I got a new pair of sneakers out of that. But I think it's a safer procedure. I think it's actually pretty simple to do. And in the right hands, it's definitely life-saving. The caveat to that is, where are you going to do it? So I would do it in my urban tactical environment, because I know I'm going to be at a level one trauma center pretty quickly. Would I do it out in the woods in an austere environment or search and rescue? I probably would not, because unless I knew I was going to have, helicopter rescue that, would be able to get me out of there, I'm not going to do that and then carry someone out of the woods with that. Going to probably do needle decompression and repeat it as necessary.
Yeah,
Little
indeed.
PRN. Yeah.
Yeah, indeed, indeed, and like you said, that semblance of being in definitive care where you can, or indeed close to a team or close to a center where
Yeah.
you can take control of their ventilation. You can start to, you can give them an RSI or an anesthetic and really monitor their. But listen, I would agree with you from a thoroughness and a robustness of pleural drainage, and you can quality assure, like you said, you can't quality assure a needle chest decompression as much as we maybe the fallacy, and we kid ourselves that we can. The actually doing and feeling the finger thoracostomy is actually the gold standard for pleural drainage. But like you say,
Yeah.
quickly followed up by a tube, or indeed a ventilatory strategy where you can actually support their ventilation. Um,
Yeah.
Steve, could I get you to speak to, you have spoken already to trauma gel. Are we seeing trauma gel become the new wound packing? Is it as good, if not better, than packing gauze into a wound?
Yeah, I mean, I haven't had the opportunity to use it other than on a human patient yet. A friend and colleague of both of us, Sarah Spelsberg, has. It was a gunshot wound through the hand. They not life-threatening, but they weren't able to get hemorrhage control, and it happened very quickly, apparently, with the trauma gel. I think it is going to replace gauze packing. One of the things that I teach and continue to talk about is that it's nice to have these hemostatic dressings, certainly. But what it is really all about is the pressure within inside that cavity that really controls the bleeding. And then, once you've got all that gauze packing in, you have to apply about 150 pounds of pressure to maintain that. And then when they go to pull it out, the surgeons, have to get proximal and distal control of those vessels. And you've got all these other side little tiny bleeders. So with trauma gel and what I've seen in the lab, what I've seen in their demonstrations, it's quickly applied. It fills the entire cavity. You apply just an additional 25 pounds of pressure, which is easier to do. And then, it just washes away with saline. So I've seen it in the pig models. I've seen it in the lab, seen it, in their videos. I think it's probably going to become the wound packing material of choice. It's probably also less painful. Packing someone's wound is incredibly painful. I'm sure you've experienced it as well as I have. They don't want your fingers in there. And it's not pleasant for anybody. And also there's some provider risk as well. I'm jamming, my fingers in there. I don't, I might be getting bone fragment or shrapnel that could injure me. I'm not life-threatening injury, but I don't want to necessarily be exposed to that. I've gone to now using McGill's forceps to pack because then it's safer. But regardless, I think the trauma gel removes all of that. You just squirt it in, it fills all the cavity. It's going to fit, create this platform for platelet adhesion. It's less pressure that you have to apply, so it's less painful. And it's pretty inert, so you don't have to worry too much about any other issues. Um, we all still have to carry, the hemostatic dressings and things of that nature, but given the opportunity, I carry two of them with me in my bag, and then I also have them, stashed if I need to get some additional ones. But that's going to be my go-to. If I have to pack a wound, I'm going right to the trauma gel.
So let's pivot again slightly. It's going to be a bit of a whistle-stop tour around your career, really, and also, but just how you approach different things. Because I'm keen to tackle a broad spectrum of topics, just to get your thoughts on it. Really, one of the aspects is you are part of a high-performing team, which has got quite a high exposure to blast and ballistics incidents in the Massachusetts area. And you're constantly going in with SWAT teams, and interacting, and as an educator. Could I get you to speak to just what you've seen from the institution's approach to mental health and self-care and wellness, and indeed what strategies the institution and indeed yourself advocate for mental health well-being when there's this high cadence of exposure, maybe high cadence of speaking to you a lot, Steve, high cadence of ballistic injury, high cadence of gunshot wounds. Could I get you to speak to that sort of mental wellness piece?
Yeah. So, I think that's critically important. I know you do as well. And it's been a real mix. The current team that I'm with, because of the leadership, we do think about that issue, and people have talked about it a little openly and freely. It's part of the briefing, part of the debriefing. We don't do it at every training, but certainly any incident, it's going to be discussed and it's going to be reviewed. And that's a positive because honestly, that has not been my experience with other teams. It has not been my experience, during my HEMS career. That was a very busy HEMS program, and the mental health piece was just simply not addressed. If it was almost felt a little punitive, to be honest. My prior ground EMS experience, you know, we had other ways of relieving our stress that were very unhealthy. I think that my pre-hospital experience, with the exception of the current team that I'm with now, it really was never a topic, and we all kept it under kept it close, our cards close to us, our chest, and the result of that is, we've lost so many colleagues. We just had a very, a guy that I worked with, for many years. He just died at 54. The year before, I had another colleague who died, 2 summers ago, at the age of like 52. I mean, we're seeing, these lifespans that are significantly diminished that I have to imagine there's some role for the mental health stressors, and then all the things that people unfortunately turn to, be it alcohol or other substances to relieve that. In the hospital, it's been somewhat better. One of my other titles is I'm a bioethicist. I did, a 3-year bioethics fellowship at Harvard Medical School, and then was a visiting researcher in bioethics at Harvard Law School for another 5 years. And so I really do pay a lot of attention to, ethics and ethical principles, but I also think that it's very much intertwined with wellness. I've had some really amazing mentors along the way that have shown me that how important, that human piece to all of this is. And I think that it's also, I think why I've really grown to love working in the ICU is you get to spend a lot more time with the patients and with your teams, and how important it, that the wellness of your team is, as well as the wellness of your patients. Getting them well requires you know, paying attention to, these underlying psych issues, stress, trauma. Similarly, the opioid epidemic. No one that I've ever encountered turned to opioids because they they just wanted to get high. Almost all of them have had underlying severe trauma, and not physical trauma, mental trauma. Even the ones who said, "Oh, I started taking pills because of a soccer injury," dig deeper and you find out there's actually a lot of psychological trauma there as well. And I think that's very much true for a lot of people in the pre-hospital environment or in these other high, risk environments. We tend not to take care of ourselves. But we've started to integrate this in that wellness piece. And I did a podcast on the Tac Medic Whiskey podcast about self-care, wellness. Self-care and wellness is a critical part, and it has to be discussed after every incident. And we have to check in on each other, make sure we're all doing okay. And we definitely need to do a much better job of that. Luckily, like I said, the team I'm with now, I think that's recognized, but it's not always been, the case.
Yeah, sure. No, absolutely. I agree on all points, actually, Steve. Just looking and pivoting slightly, me and you both been involved in the FDNY MSOC conference, the Fire Department New York, and they're really responsible for pushing the frontier of pre-hospital care within New York and wider, actually, because it really is a conference of collective minds across the US. Could I
Yeah.
get you to speak to? Just you've been there recently, you've just been out there over the last few weeks, just around protective gear within tactical medicine and just the evolution of equipment that you've seen around protective gear for practitioners. Has it started to become a lot more robust and indeed inclusive of things like eye protection and otherwise?
Yeah, no, absolutely. So with my team, if you are on the range, you're in training, or we're on a call, you have to have your graded eye protection, Kevlar helmet, and level 3 vest, with or without plates. So for that team, 100%. I have, however, seen, a lot of different varieties of that for other teams and other units. Um, I've seen teams and they're not wearing their eye pro. That's simply not acceptable for our team, but other teams may be doing that. We also have something called the Rescue Task Force, which is, I'm in the hot zone with my team. I can go in the stack because I train with them. We train twice a month. We go out on calls. So I'm training with them and doing that, and I'm well protected. I've got all the right gear. And there are some medics that do hot zone calls like that as well. The majority probably are going to stay in the Bearcat or stay shielded. And I've done that too. The last call out we went to, I was in the Bearcat. Um, and it was a high risk warrant. But you still want that protective gear. But we also have something called the Rescue Task Force, which a lot of U.S. EMS agencies and fire departments are going to, which is warm zone entry. So this was lessons learned from, our several of our mass shootings here in the United States where if you don't get in there quickly, people are going to die, right? And so, law enforcement's going to get in there, start taking, property, start taking territory, and the rescue task force is going to come in behind them. So they're not in the hot zone. They're in areas that have been cleared, but they're going to be entering in a warm zone with a potential for possible injury. And I've seen lots of different varieties of gear for that. So I think we do need to be better educated about if you are going to be doing this, you have to have the right gear. And that starts with, Kevlar helmets, iPro, minimum of a level 3, vest, which is going to get most handguns, some rifle. I have ceramic plates, they help, for any, sharp instruments like knives, things of that nature, but also, also some rounds as well. I can't say I'm incredibly well versed in which rounds, stop what, but that I'm gonna have the highest level of protection that I possibly can for doing my job. And I think that's critically important. But I think that a lot of people we focus on the medicine and forget about the equipment. And so it really is important and to make sure you're not just getting hand-me-downs. That, oh yeah, here's the vest for the medic because you know Joe quit and whatever. So here's your vest. No, it has to be you're a member of that team. You are equipped at the same level that every other team member is equipped at, and that's critical. And I think I've seen all variations of that. So
Yeah, indeed,
yeah,
indeed, yeah, indeed,
yeah.
and absolutely to all of those points, actually, Steve. Just looking at, we've got a couple of more questions really as we come into land. One would be around technologies in the space. You've spoken about the trauma gel, yeah, and just the advances there. But could I get you to speak to any emerging trends? We've all spoken about, but I mean, and we can't unstate this about the administration of whole blood products and the utility in offsetting mortality. And we will signpost to your podcast actually because in the show notes you've done some fantastic work on that and covered that off. But we'll what I'd like to do is just get any technologies and or innovations that really seem to be evolving in the space of tactical medicine that you're aware of.
Yeah, one is pretty simple, and this is how do we move our downed officers. So it's a beast, right? We trained yesterday, and we were doing some movement of a downed officer who's one of them actually was not in any gear, but the other guy was full SWAT gear, and getting them moved is incredibly difficult. So very simple technology that already exists. We certainly have those people carriers, the nylon litters that we use, but then bringing that out to a backboard because lifting a patient on a litter into a Bearcat, which is much higher than an ambulance, is incredibly difficult. We were doing some training. We were trying it, and one of the gun belt and Molly got caught on part of the door. We couldn't get him in, trying to get him in. So it wasn't my idea. It was someone else's idea, but like, you need to have a backboard in your Bearcat. Have a backboard, throw them on the backboard. You now have much more ability to get them in. So that's not an emerging technology. Backboards are really going away here in the US, but they still have a role, not in immobilizing that person's spine, but just in moving them. So that's one. The other is video laryngoscopy. I think every EMS agency should have shifted to video laryngoscopy. I carry a glide scope Go in my bag. And you're not going to be maybe intubating in the incident, but if we get them to a safe environment, I want the best tool in my hands, and video laryngoscopy, I think we're now learning is the best tool for intubation. So I think we need to see that. Then I think we need to see some more work along, intra-abdominal injury. So, we need something that maybe like trauma gel that you could get into the abdomen to maybe, get some bleeding controlled. I'm sure the surgeons are like out, we don't want something that's going to create a mess, but maybe something that could get in there that, could at least help. But lastly, and this has been a big focus of mine, is junctional hemorrhage, and we need some better devices for that. I think the junctional tourniquets that we have out there are really difficult to use. They're not compact. There's a lot of working parts and pieces. So what can we do to better, manage junctional trauma? Because those are the injuries that we're going to see in our tactical environment, right? You're wearing Kevlar helmet. You've got, the vest that covers most of the chest, but it's abdominal and then junctional. So maybe technology around how do we protect those spaces, and then technology on how do we manage them if there is a penetrating injury to a junctional, area. So I think that's where I'd like to see maybe some, creative insight into what can we do for these junctional injuries that we can't do now. For the neck, I carry Foley catheters and epistaxis balloons, right? For the groin, axilla, groin, it's going to be packing it, putting pressure on it, those kind of things. But we need maybe some technologies around junctional hemorrhage.
Yeah, indeed. No, indeed. Just finally, actually, Steve, just as we come into land, you've mentioned already around, compliance to safety kit and indeed to sort of tactical uniform just as a prerequisite. Like the fundamentals of just wearing eye protection, as a standard. But if I could get you to speak to just one, if you could give or implement one change across training protocols in tactical medicine globally, well, notwithstanding, compliance to like this, because the basics often are the
Yeah,
life-saving things actually. But if
right.
there was indeed sort of one change to training and/or protocols, what would it be?
Yeah, I think, and we've just started doing more of this, which is practice doing the actual officer down carryouts. We all know the medicine, right? The medicine is actually easier. I mean, when I'm in the ICU and I get this patient who's got pneumonia and they're confused and they have a sodium of 122 and renal failure and this and that and the other thing, that could be complicated medicine. This is not. This is gunshot wounds or ballistics, explosives or falls, right? All of those things, we know the tools, we have the tools for that. But like knowing how to carry someone out, actually feeling that, is important. I think you need to practice coming up, identifying who you are. It's important to then secure their weapon, because you don't want someone who's in hemorrhagic shock and confused to be reaching for a weapon. So practicing that and how to safely handle weapons is important. I don't think a lot of teams practice that, but coming up, identifying, securing that weapon, doing it safely, and then really practicing that movement that you have to do tactically, because you're still going to need operators, you're still going to need shooters getting you out of there in certain circumstances, because unless they've taken care of the threat, right, there may still be active threat. How do we get them out in that? The other piece that we actually talked about this yesterday. I was thinking about this at MSOC because our practice is get them to the Bearcat, then the Bearcat's going to get us out into to where we can transfer them to an ambulance. But what if you need that Bearcat there, and that is your only, that's your cover? So how do we get people out? So I think thinking about those unusual tactics, it's fun to smash doors down. It's fun to rake windows, right? It's fun to throw the tourniquets on, but it's not fun to figure out, okay, how are we going to move these people out safely, tactically? And then once we get them out, where are we going to go with them? And that's the whole idea of casualty collection points, which you have to realize that those need to be practiced. But what are we going to do to get that now victim out of the scene safely? And is the Bearcat our best option, or is a Bearcat not going to be our best option? And do we need to think about how we can extricate someone from that scene safely? So we're going to be integrating that into our next training. Yeah, I understand, to see, all right, what if we can't use the Bearcat? How are we going to do this? And I think there will be some interesting, things. 'Cause the other vehicles that we have for transporting people, they're not armored. They're like bread trucks. So, do you want to be under fire in one of those things? And are there ways to do that? So I think that's those things, don't we oftentimes, stop the scenario at that, right? Get the tourniquet on and get them on this litter, and we're like, okay, we can stop the scenario. Let's do the next rotation. But I think completing those two, to the end is really important to practice because we've learned some really good things. The backboard was one thing we learned. We couldn't lift him in. We got caught up. The backboard was an easy solution to now you can just slide them right in.
Yeah.
Um,
Listen, you
it's
make a
super,
fundamental
super easy.
point. Yeah,
Yeah.
the logistical aspects of care shouldn't, like you say, shouldn't be negated because they are super challenging,
Yeah.
especially 5 floors up. Lifts
Yeah.
maybe not working. You
Yeah.
3 or 4 gunshot wounds. And actually, this, that is a super challenging scene, and bringing, like you said, bringing that to the fruition of training rather than stopping at the door. There's definitely lessons to be learned there.
Yeah, yeah. No, we did a full week long training. It was fantastic, and we used a CCP, so it was still active threat going on, but we brought them to the CCP. The shooters are engaged, and they're still engaged because we cannot move those people out of there. So I had to, we moved them into a CCP. I'm going to manage them the best I can, and then we're going to have to wait till the shooting's over, right, in order to get them out. So you've got to think about those logistics, and you might be managing 2, 3 wounded officers independently in a CCP, and how do you secure that CCP? And so there had to be 2 guys, or 2 operators, because we do have a female on our team as well, standing there to provide my protection and practicing that. If I'm going in on the stick, practicing how making sure that the medic is protected at all times. And yesterday we had one scenario where I'm outside treating somebody. Those guys are shields up, guns on the house, protecting me 100% of the time, right? But if you don't practice that, they might be looking down at you, and that's not what they want to be, you know,
Yeah.
shouldn't be doing. I also do it too. Like I want to peek around the armor and see what's going on while they're smashing breaching the door. But I really should, if I'm not in the stick at that point, if I'm staying in the Bearcat, I really should be staying in the Bearcat, so, but we want to see the action. But I think you've got to practice those things and practice them a lot, and you learn a lot from doing that.
Listen, thank you, Steve. It's
Yeah,
fantastic just to do a bit of a whistle stop tour through your
yeah.
practice and experience. But we'll put in the show notes a link to the podcast, and it's absolutely fantastic. And I do recommend listeners go and check that out. So,
Well,
but listen,
thank you for
thank
doing
you.
that.
No, mate, listen, thank you for the last hour. I really appreciate it.
Yeah, well, I appreciate it, and I appreciate what you're doing with this podcast and your Restore podcast. I think they're critical, and valuable. So I really appreciate what you've done.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.